going to discuss about diagnostic challenge of recurrent post-COVID-19 ROCM with various presenting features. No financial interest. Rhino-orbitocerebral mucormycosis is a rare, opportunistic, devastating angio-invasive fungal infection caused by the filamentous fungi such as Mucor, Rhizopus, Apsidia of Mucoraceae family of the order Mucorales of phylum Mucoromycota of the class of Zygomycetes. Mucormycosis can be classified as one of the 6 forms based on anatomic localization. Of them, rhino-orbitocerebral mucormycosis is the most common one. ROCM usually occurs in immunocompromised individuals such as hematological malignancies and post-transplant patients due to uncontrolled diabetes mellitus, inappropriate steroid therapy, neutropenia, and elevated free iron levels. ROCM recurrence has shown a rising trend in the setting of COVID-19 pandemic due to prolonged use of broad-spectrum antibiotics, steroids, immunocompromised state, incomplete treatment due to shortage or high demand of drugs. The clinical and radiological features of mucormycosis overlap with other conditions for which a thorough diagnosis should be made. Materials and methods include: it is a cross-sectional prospective interventional study. It includes 30 patients with recurrent ROCM following COVID-19 infection over a period of 1 year. Patients who were referred to ophthalmology department from various specialties including general medicine, neurology, general surgery without documenting prior history of post-COVID-19 ROCM. All patients who presented to our OPD with facial sinus, tooth pain, facial swelling, facial numbness, nasal stuffiness, periorbital swelling, double vision, decreased or loss of vision, fever, headache were suspected to have mucormycosis infection. A thorough and detailed previous history regarding COVID-19 and mucormycosis was carefully taken and documented. The patients were then evaluated thoroughly with complete nasal, oral and ocular examination. DNA was done for all patients and deep nasal swab was sent for microbiological examination with 10% KOH mount, culture and sensitivity. Then sent for radiological investigations like CT scan and MRI orbit, followed by blood investigations. The microbiological report was observed and noted for all patients. After doing DNA, radiological findings along with indicative signs and symptoms and microbiological confirmation, patients were diagnosed to have recurrent ROCM. Results include: total number of patients are 30, of them right eye was involved in 14 and left eye was involved in 16. Age distribution, mostly between 41 to 50 years. Of them, males were predominant of 63%, and duration between COVID and ROCM was around 20 to 25 days, and duration between first and recurrent ROCM is 3 to 6 months of period, and comorbidities are mostly diabetic and followed by steroids and hypertension. Diabetic, the HbA1 levels are around 6 to 8 in most of the patients. Presenting features include proptosis and facial edema in most of the cases, and followed by chronic headache and restricted ocular movements, followed by seizures and lacrimal abscess, and chronic eyelid edema, chemosis with discharge. In this case, presented with complete ptosis, proptosis and chemosis with discharge, we initially thought as orbital cellulitis. In this case, only mild ptosis with restriction of extraocular movements were seen. And in the below case, chronic lid edema with discharge and congestion are seen. Lacrimal abscess and conjunctivitis are the presenting features in these two patients. Of all the patients, visual acuity, most of the patients have no PL in 20 cases, and PL and hand movements are present in 4 cases, and less than 662 hand movements in 6 patients. Of them, maximum showed fundus as optic atrophy. In KOH mount, Rhizopus showed in 18 cases, followed by Mucor and Aspergillus. Cultures also the same. Radiological features, most of them orbital involvement is the maximum and followed by sinus involvement and intracranial extinction in 3 patients. CT showing orbital apex involvement and MRI showing intracranial spread. These are the DNA findings in most of the cases. Treatment undergone for first episode include endoscopic debridement in majority of the cases. Of 27 cases, only 3 have maxillectomy, and antifungal treatment include injection liposomal amphotericin B. Those 23 have completed the treatment and 2 have incomplete, and injection posaconazole tablet posaconazole was given to all the 30 members. Coming to discussion part, the present study included 30 patients with recurrent ROCM following management for ROCM post-COVID-19, out of which 19 were males and 11 were females in the ratio of 1.7:1. The most common risk factor associated with recurrence is incomplete treatment during first episode of ROCM, including endoscopic debridement, being the major cause, showing 89%. This is supported further by evidence of recurrence of 56% in less than 1 month duration. Also, patients with immunosuppression like uncontrolled diabetes with HbA1 levels of 6 to 8 mg in 76%. Due to the varied presenting features like orbital cellulitis, mild ptosis, chemosis, isolated chronic lid edema, headache, has led to lack of accurate clinical suspicion and prompt referrals at the earliest. Based on the clinical features, these were subjected to series of diagnosing modalities, and this resulted in delay to diagnose. After progression to complications like seizures, orbital apex syndrome, a strong suspicion arose and was aggressively investigated further. Coming to mucormycosis, post-COVID mucormycosis is most commonly caused by poorly managed diabetes, and airborne fungal spores can trigger the foreign body inflammatory response, which results in the creation of a thrombus, which in turn causes ischemia and necrosis, which is the reason for darkened tissue. The infection later on travels to the orbit from the infratemporal fossa, superior part of orbital fissure, ultimately reaches the lamina papyracea. Diplopia, chemosis, congestion and restricted extraocular movements are the early indications depending on the affected site. Optic atrophy, total blindness and ophthalmoplegia are all late symptoms. Tissues are surgically debrided and injection amphotericin was administered. Antifungal agents include mainly posaconazole as the first line drug. In this study, incomplete surgical debridement, uncontrolled diabetes and excessive corticosteroid use could have triggered the recurrence, as hyperglycemia causes the adhesion and penetration of mucorales by increasing the bond between endothelial receptor glucose related protein and morel regulated protein. Now being an angioinvasive fungus, this adhesion is vital for spread of disease. I conclude by ROCM is a devastating angioinvasive disease. Recurrence of ROCM is mainly due to diabetes and surgical treatment with endoscopic mucosal debridement alone. Early diagnosis of its recurrence by multidisciplinary approach has aided in giving appropriate treatment and preventing further intracranial spread despite various clinical presentation. Thank you.
Oh, thank you. So what were the areas that were biopsied? You've mentioned biopsy as confirmatory test, right?
During DNA, we have taken the samples from nasal specimens.
Okay.
Intracranial extension we didn't take.
Okay.
Mainly from the other, based on the MRI and CT, we have confirmed the intracranial spread.
So you have used injectables, amphotericin and posaconazole, right? So out of the two, how fast is the response and why a tablet in certain cases? So how did you segregate which one to choose based on what?
Was given, ma'am.
Okay.
Based on the availability only we have given, because it is a GGH. We never.
Yeah, got you. All right.
What is the follow-up period?
Sir?
Follow-up period of these cases?
From October, we are getting cases, sir. Like 3 to 6 months follow-up.